Hello, friends. We are back again, radiating my warm greetings to all of you. Hope you are in your wink of your health and spirits. So today's topic of this video is I have left this topic in the last slide of the video, and this is concepts and tools for gender analysis in health. So in the last video, which was on introduction to sociology and social medicine, I have left this last slide to prepare for the today's topic, which is an already uploaded video on the YouTube on gender and health, IAPSM Citizen Health, episode 58, which was a discussion on International Women's Day, which was the theme was break the bias, and where I have discussed what is gender, what is health, what is equality, what is inequity in gender, what is discrimination, and how gender is as a social determinant of health, and what are the linkages of gender and with other social determinants, predominantly health. So if you have not done that, you should go through this video, gender and health, before going through this today's video. Here are certain sentences given, which is your homework, and you have to write down whether these sentences relate to gender or sex. You can fill up sex and gender columns, so you have to do it on your own. Today's specific learning objectives will be that at the end of the video, you will be able to describe concepts of gender analysis, become familiar with the tool for gender analysis in health, be able to apply the gender analysis tool to a specific health condition and arrive at an understanding of how gender impacts on health. This is a review slide from the previous gender and health video. Friends, we know that what we are, what we do, and what is our life, and what resources we have, how much access to those resources that we have are all related to health. They have a bearing on health. And men and women, they occupy different spaces, a range of activities which both of the genders do differs, and all of them are based on governed by certain social norms. Again, there are differences in accessibility and availability of resources to them, which is a very important bearing with the health. We will see in the coming slides. Just for review, what is sex? Sex refers to the biological characteristics of male and female, predominantly genitalia, reproductive organs, chromosomal complement, and hormonal environment. So it is given by God that because of the reproductive organs are different, only that should be the difference. Why other differences come up? Gender refers to the socially constructed roles, rights, responsibilities, possibilities, and limitations that in a given society are assigned to men and women. In other words, to what is considered masculine or feminine in a given time or place. So, what the biological part should refer to sex, and all other things are related to gender. And when we talk of gender, we will talk of feminine and being masculine. And if we talk of biology, then we will talk of the male and female sex. So this was just a review. So does gender matter? There is an exercise for you at the end of the presentation, which you have to answer to these questions. Right now, so if there is gender matters, then what is gender analysis? Sometimes we think that gender analysis is same as sex disaggregated analysis, but it is not. When we are doing sex segregated information, it is based on male and female. But gender analysis means whether and how socially constructed differences in women's and men's living conditions, roles, status, behavior, and perceptions affects a specific health condition. So if gender analysis is not equal to sex analysis, then what are the tools? Uh, so if gender matters, I have given this slide first because just as an example, you can see that from the census 1951 to 2022, we see that literacy rate has been increasing overall. But when we see that what is the literacy rate in men and women, males and females, there is a gap everywhere. In 1951, the gap was of 18, and then in 2001 the gap is of 21. Still we have a gap of 16. The gender segregated literacy rate, which is not available from the 2022 information. Still from 2011 we can say that there is a gap, though the gap is being filled over the years. Here, friends, I have taken few examples to stress upon the point. Yes, gender matters and how it matters. Yes, here I have taken some examples. One from the communicable disease, one from the non-communicable disease, and just to see these diseases from the eye lens. So I prefer that word, having a gender eye or a gender lens, to see what are the differences, and they would definitely be helpful in bringing up effective and efficient programs and policies. So a case of blindness, the reference is given in the slide. If you are interested, you can download this reference and you can see the full article. But here I have taken few slides from that to explain why gender matters. So in case of blindness, at the outset, you would think that with a problem like blindness, why there should be a difference? It has nothing to do with being male and female. Let us see the slides. So in this, it was the study showed that, the blind people from China, India, and Africa were 30 millions in this study when this was conducted. The overall prevalence is some number is more than 40, might be more than 40 million that time. And this study was done in these regions. So we are talking about these regions over here in this study, taking the WHO definition. So there are it says that there are overall there were 30 million blinds from this region. Now let us see the male and female differences. When we segregate this data, then we see that the study says there are 20 million women and 10 million men from 30 million. What is the difference? Why is the difference? So people started, trying to explain what can be the possibilities of this difference. And some might say that, because the women have a longer life expectancy at older ages, there are more women seen than men, and blindness is a degenerative conditions there. So that might be one of the explanation. The other explanation would, but when we see that the mortality specific rates among men and women throughout the years, it shows that there are the mortality rate is greater in women as compared to men at all ages. So this can't be a plausible explanation for that. So what can be the other reason? Differential mortality. Why the differential mortality among blind men and women at all age groups? That there must be some other explanations for this reason. Another one, some people tried that because trachoma is more common in females, because females are in caretakers and they be with their children during the childbearing ages, and that's why they might be contracting trachoma, and also the indoor air pollution. But when we see that these blindness are very small in small numbers as compared to the overall causes of blindness, so this also cannot be a plausible explanation. So what is the other explanation? Now you see this. What happened? They also explain in in their paper that in 1958 China started a program for reducing blindness. So a program came up, and from 1958 to 1987, the data shows that the number of blind men and women, the reduction from 1958 to 1987 shows that there has been reduction as a result of the program in the blindness, but it shows that the blindness decreased to a greater extent in men than in women. Yeah, this is one of the things that we need to take into consideration. So, if the blindness program was there, it should have treated men and women equally. But there was more reduction in men, sorry, as compared to men. So, here comes the underlying explanation that is because of, they explain that it is because of differentials in access to and availability of eye care services, which is different in men and women. And also because of the differential roles and differentials in behavior of care given to men and women. So, what should be done? Yeah. So, if this is the case with the problem which should have nothing to do with blindness, what we need some differential strategies for women to reduce the blindness. So that should be there should be a gender specific aspects in the program to deal with this problem. This is one of the example. So reduction in men was 66%, women by why so can be explained by there are differentials in access to and availability of eye care services to women, not only blindness, other programs also we find similar picture, and so we need women specific programs. Uh, the Vision 22 was the vision that time, and they explained that we should increase the women's access to and utilization of eye care specific services through gender realities of the intervention area. Now, there are so many other conditions that can be explained where social factors are the determinants, like malnutrition. Is it a case of gender or sex? Over the years, I have seen that malnutrition is more in female children as compared to men. You can see the various resources, the data of NFHS and other household surveys, and which confirms that. But when I went through a slide, you explain this slide on your own to understand. The another slide that I went through is I saw the female differences for malnutrition in under 5 in NFHS data. I was very happy, and I'm putting the figures over here, which says that the malnutrition in males now is higher than females. So the programs are doing wonderful in terms of bridging the gap, and there are programs for girl child which might be helping to see this picture. So this is the picture we need to see in future. Now, another problem like HIV and AIDS, there is a reference over over here. You can download the reference and go through the details. This one of the graphs from this study shows approximate percentage of adults living with HIV/AIDS worldwide by sex, and it says that there are similar number of male and female having HIV. So this is the slide. Do we believe? So what other things, now this is a problem where prevalence and incidence is the same, but still we see that the health and of women who is living with HIV is lower than that of men. What can be the reasons? Now, prevention, there are similar prevalence, but there are differences in other aspects. The social factors, like prevention की बात करें तो men can use a condom, but women most of the time don't have a say in that. Women often are not free to refuse sex in most of the societies. The HIV testing, women often risk physical abuse and abandonment when the HIV test is found positive as compared to men. I have many stories for this to say. We can chat another time. Treatment. In treatment, also, we see that the access and control over healthcare, that is ART, is available more to men as compared to women. So the problem which is having similar prevalence, but there are other factors which is affecting the lives of men and women differently. Practice time, friends. So violence also can be a case of gender and sex. One hint I can give that there are violence due to war, due to crimes, and there can be violence due to abuse and other violence, and because of wars and crimes and all, the violence among men is more as compared to women. But domestic violence, if you talk about why it's happening, so you can you can keep these points in mind to explain and try to find out studies where which shows yes what are the type of suicides are seen more in women as compared to men. I'm giving you certain hints to practice this aspect. So these are some of the inequalities in statistics. Population of female is 66 crores versus 71 crores of men. So why the difference? God gives male and female equally. Literacy rate we have already, and there are other sex ratio and juvenile sex ratio and dropouts in the school after primary education. Why that is happening? You can go through these two slides, and these are very updated and latest figures. So what to do? What is the solution? So as we are doing the sex segregated data, we can do easily. Can't we do gender analysis? So let us see what is gender analysis. Gender analysis in health is a systematic examination of the ways in which gender roles, norms, power differentials between men and women affect their vulnerability to health problems, their ability to deal with it, and its long-term consequences to their life and health. So this is what ginger analysis. I've already earlier explained that women and the physical context in which people, men and women work, the tasks they do, the people they interact with have a bearing on their resources and also on their health. As a consequence, there are socio-economic context because women have lesser control over money and other resources, which is not like even in education and training. There are the literacy rates we have seen. So the physical context differs, the socio-economic context differs. What are the consequences? So gender analysis, we need to understand what can be the consequences. Like differential, if there are differences, there will be differences in the risk and vulnerability to infections and health conditions. There are differences in perceptions of health needs, an appropriate form of treatment. In blindness, we have seen that women, they will send their men to take care, and they will say, I will be the other one, first you take care of yourself. So that's why in many health problems this happens. So there are different perceptions in women about their health needs and the form of treatment. Differential access to health services, maybe transportation, maybe money, maybe time. They are the secondary citizens most of the time to avail health services. So what happens as a consequence? The outcomes from diseases, disability, and death will be different, and the social consequences as a result of ill health. An example, we have seen that HIV. There are cases of abandonment and abuse. So why do we need a gender analysis? We need gender analysis to collate information and synthesize it from a gender perspective. to have a gender eye, to have a gender lens, to look into all data. To understand, now having information, we need to understand the fault lines. Where are the faults happening in the disease or health conditions from the perspective of its impact on men and women differently, and to develop programs that will address the gaps created by this fault lines. How can we do that? So there are some frameworks available like Pan American Health Organization framework, there is Liverpool framework, there is the WHO framework, or we can develop our own framework to suit our needs. So we need some frameworks to do the analysis. What do we need? So to do an analysis, we need evidences, as I have shown you two studies. So you can have certain studies published or unpublished information, literature or research, and then try to see them from the gender eye by doing gender analysis. So it is useful to analyze health policies from a gender perspective, to analyze programs in a from a gender perspective, to analyze literature from a gender perspective, and it can also be effective in evaluation and monitoring tool if we have mechanisms set a priori. And now, so we will review. So I have listed some of the tools, and we will take an example. We will review one of the tools I will be using here, WHO CARO, gender analysis tool of 2001. I have put this in the reference. You can go through the tool. This tool basically, what it does, it asks certain questions for each data in terms of vulnerability, health-seeking behavior, experience with the centers, ability to access health services, preventive and treatment options, and outcome of health. And then these questions, these aspects, they ask questions. So in these aspects, are there sex differences? Are there biological differences? How do the differences in roles and activities affect men and differently? How do norms and values affect men and women differently? And how do access to and control over resources affect men and women differently? You can take a print of this and try to take any of some literature and try to see by doing the gender analysis. So I will use here, the problem that I will take is gender analysis in HIV AIDS and its impact on the different characteristics of gender on men and women. This is example from a study from one of my PG student who had done dissertation on this, and our dissertation was on gender perspective. Study of HIV positive cases attending Integrated Counseling and Testing Center, Baroda, Gender Perspective. So the center at that time was known as ICTC. I think it was somewhere in 2007 or 8. Mohsin Sheikh, if you're watching this, hello and hi. I'm presenting your findings. Okay. So the study had the objective that with a gendered approach to understand the health-seeking behavior and reason for attending ICTC in HIV positive patients, to understand the possible high-risk behavior of having acquired HIV/AIDS among these positive patients, to understand the social support system and gender discrimination, if found any, in these patients, and to assess the knowledge of HIV patients regarding HIV and AIDS. So these were the objectives. So some qualitative data tool was applied with open-ended questions, and for some information, it was a closed-ended interview questionnaire. The matrix was used, as I've earlier said, when I showed the tool. We saw for incidence, prevalence, health-seeking behavior, access to the services, health outcomes, and socioeconomic consequences. So in health-seeking behavior, we found that more males preferred to go to private initially, and more females went to government hospital. So indirectly, we can say that more money was spent in their healthcare, and because women were sent to the government setups to do. Three females went to quacks, none of the males went to quacks. And now, some eight males went to ICTC directly. Economic factors were major determinants. Females had less control over income and had to use her own income, which was already very limited. Males decided the treatment for females. That's why, where they would go for services. Females had less knowledge and awareness regarding HIV/AIDS, prevention, condom usage, and high risk behavior. But one very important good finding that we had was experience with VCTC counselor. There was no significant differences in the provision of healthcare to either gender. Vulnerability. Majority of the males were involved in high risk occupation like truck driving, auto driving, call centers, and they were doing sales work. Higher number of males had economic responsibility to run the family as compared to males, and more than two-thirds females were dependent on others' income to run their family. In majority of the cases, spouses were HIV positive, and almost one-third cases did not know about the HIV status. One-fourth of the HIV positive patients had a past history of blood transfusion. Majority of the males were involved in high-risk behavior. There was a history of premarital sex in 83% males, and history of extramarital sex in 64% of the males. So there was a difference in the vulnerability. Social support system. HIV status was discovered by 85% of the cases without much gender difference, as they thought of seeking support from the spouse, family, and society, with 43 cases disclosing to their spouse, 45 to their family members, and 17 to this. This was a good aspect that most of them had disclosed their HIV status. But more number of females experienced careless behavior and were neglected by their spouse or family or society after disclosure of the HIV status. 9% of the cases were culprit of domestic violence, of whom majority were females. Overall, more than half of the patients were disturbed physically, mentally, and economically. This aspect was found more in males. More than one-third cases had suicidal tendency in their life, of whom majority were females. So even males are vulnerable because, I have talked about this in the gender and health video, that even males have their problem due to being males. So this aspect also need to be addressed through, if there is a risk of such differences, if there are differentials, men's program also should be, the men's issue should also be included in the programs. Preventive and treatment options and response to treatment. More number of males were on ART. See, more number of males were on ART as compared to. So again, it says about access to and control over resources and healthcare. No significant difference was found in the improvement or adverse drug reported after ART use. So this aspect was equal, but in the provision of healthcare by the healthcare providers. Outcome of health problems: physical, mental, financial disturbances were more in males. Suicidal thoughts were more in females. Social consequences were more in females, and economic consequences were more in males. Regarding knowledge about the problem, only half of the patients could answer that HIV can be spread by sharing infected needles, while only 22% could answer that there is a mother-to-child transmission. 41% cases could answer that use of condom can prevent HIV, of whom majority were males. I again want to say that this was 2007-8 study. So we are talking about that time. Females had less knowledge and awareness regarding HIV/AIDS prevention, condom usage, and high risk behavior. So there was the knowledge about this was not complete in both the genders, more so in the females. Behavior. So what was we recommended from the dissertation was behavior change and communication strategy for males to decrease their high risk behavior, and the counseling center services and testing services should take into account the family dispute if there is in familial relationship and violence related consequences when evaluating different approaches to disclosure status, and should provide adequate and enough information in counseling regarding ART window period and spouse disclosure. Though there was no difference seen in provision of counseling by the counselors, but every program should always have stress upon gender sensitive training to the counselors. Would be helpful to have gender perspective counseling specifically in HIV disclosure and higher awareness in the general population. So this was the actions recommended. This is I was talking about the WHO framework, and this is the frameworks. The study findings from the study are inserted into it. You need to go through it, how this was done. So this is a good example of gender analysis of HIV and AIDS. I'm giving you another study here to do as a homework. So this is a study on gender analysis in control of malaria, where insecticide treated bed nets was the intervention. Go through I have already filled the framework for this as malaria aspect also. You just go through the framework and find out how this was filled up. And if you are interested, you can download the study also. So to conclude, friends, we have seen that a condition which disproportionately affects women, even though there is no a priori reason to expect that it would, like we see the example of blindness. A disease which affects men and women about the same amount, that is HIV/AIDS, the example in the aggregate, but which has a very different implications for each gender. So gender matters. Yeah, gender matters. Now you must have made some mind that yes, gender matters. This is a practice time. This also can be one of your theory question in some exam. You have to give your critical comments on the following statement. Health projects automatically address women's empowerment. Critically review and comment on this. This is one of the practice time for you. So the message is the gender analysis tools can be applied to one condition, several condition. It differs from one condition to other condition, but the fact is that gender has a great bearing on the lives of men and women, being male and female. It interacts with other determinants of health like education and education. Very important one is education and health, and so if and poverty. Yes, poverty. If we see that people are poor, if we see the BPL data, you will find out that if people are poor, then there are more poor women as compared to poor men. So looking at health with a gender perspective teaches us about factors that give rise to and sustain disease and disability, factors that we might not notice without a gender perspective. I like this word, gender high and gender lens, gender perspective. So knowing about these factors helps us to better fight disease and disability. So in our surveys, Gender matters. Gender matters a lot. So let us ensure we will, as a matter of policy and good public health practice, integrate gender considerations in all facets of our work. Let us take an oath today. Integration of gender considerations, that is mainstreaming gender into health programs, should be the standard practice. All programs will collect disaggregated data by sex and also review and reflect on the gender aspects of their respective areas of work and initiate work to develop content specific material. Most of the time, we don't have data on men and women. Separately, even in our books, you will see the Hippocratic Oath also says he should, like, he is there. There is no she over there. So our language also should become gender sensitive. So knowing is not enough. We must apply. Willingness is not enough. We must do. These are the essential readings you can have. So friends, my next video, which is it will be on topic indicators of health. So gender feelings are so tender. They are so tender. Let us work on that. With this, I stop here. Thank you. Like and share and subscribe to my channel. Have a day as lovely as you are. Thank you.